Good morning, everybody, and welcome on behalf of the Mirowitz Center. It's my pleasure to thank you all for joining us today. We have a very distinguished guest with us, Dr. Michael Rich, who is an international expert in geriatric cardiology. Dr. Rich is a graduate of the University of Illinois, and he sent me a very condensed and, I believe, deliberately concise biography, which really doesn't touch on all his accomplishments and all his talent. I will tell you, however, that he's been twice at least the Teacher of the Year at Barnes Jewish Hospital. He is a Distinguished Fellow of the Society of Geriatric Cardiology. He has received numerous awards. He has a great number of clinical interests, and his research is extensive, as is his publications. But as I looked through the publications, I realized there was probably no prospect of my being able to understand any of the things he's published, but his peers certainly seem to appreciate and value what he's written. Dr. Rich, we're so happy that you've joined us. We thank you for being with us, and we look forward to your presentation.
Thank you, Stephen, for the kind introduction, and good morning. Thanks to all of you for joining. I'm going to share my screen here, and hopefully you can see this. So as Stephen mentioned, I've had a longstanding interest in geriatric cardiology, heart disease in older adults, and this morning I'm going to be talking about atrial fibrillation, or Afib, which is a very common heart disorder in older people. And I suspect that many of you in the audience today have either fibrillation or know somebody who has had it, because as we will see, it's very common in the older adult population. So let me begin by, looks like I can't advance my screen here. I'm going to have to stop sharing and all right. So sorry about that. So let me begin. This is going to be basically an introduction to atrial fibrillation. And the first question is, what is atrial fibrillation, which is also commonly referred to as Afib or sometimes just AF. And this is a depiction of the heart. And I hope you can see my pointer. But on the left here, as many of you I'm sure are aware, the heart has 4 chambers, 2 upper chambers, which are referred to as atria, and 2 lower chambers, which are referred to as ventricles, and the lower chambers are the pumping chambers of the heart. And there's 2 chambers on the right side and 2 chambers on the left side. And the impulse of the heart, what causes the heart to beat, originates from a little node up in the upper part of the right atrium that is known as the sinus node. And this is the pacemaker of the heart. And it will generate a heartbeat at regular intervals. And this heartbeat will spread across the atria and then down through what's called the AV node into the ventricles. And this will activate a heartbeat. And we can see this on the electrocardiogram. This shows this little bump here is called the P wave, and that shows the activation of the atria. This is referred to as the QRS, and then activation of the ventricles in a very regular and organized fashion. What happens in atrial fibrillation, shown on the right here, is that the sinus node stops functioning normally, and there's a very rapid and chaotic and disorganized beating of the upper chambers of the heart, which is known as fibrillation. And since it's the upper chambers of the atria, this gives the term atrial fibrillation. And these impulses are frequently bombarding the AV node, And some of these impulses will go through the AV node and cause the ventricles to beat. And what we see as a result is an irregular beating of the lower chambers. And so these QRSs, which are the beating of the lower chambers, become irregular and chaotic. And we also lose this P wave as we no longer have the organized beating chambers of the heart, and you see more of a squiggle down here. And so this is atrial fibrillation, and it's very common. It's in fact the most common and important heart rhythm disorder, but the frequency of this condition increases progressively with increasing age, as shown in this graph. And so we can see in people under the age of 50 years old, it's actually pretty uncommon or rare, but with increasing age, it becomes increasingly more common, so that in people over the age of 80, both men and women, roughly 10% of individuals will have atrial fibrillation. It tends to be more common in men than in women, shown in the darker gray here. And it also tends to be more common in whites than in blacks or Hispanics. But particularly after age 80, because there's substantially more women who survive past this age than men, we see at least as many women with atrial fibrillation as men overall. There's several different forms of atrial fibrillation, and I'm mentioning this because you may hear these terms. One is called paroxysmal atrial fibrillation, and what this means is that it comes and goes. So sometimes the person will be in normal rhythm, sometimes the person will be in atrial fibrillation. How often this happens is highly variable. Some people may have an episode of atrial fibrillation only every couple of years. Others may have it several times a day, and it can be of varying duration as well. It can last for minutes to hours, sometimes days. So that's paroxysmal. It means that it comes and goes. Another form is called persistent atrial fibrillation, and this just means that it's present continuously for at least 7 days, but it still is reversible. That means that it could still go back into a normal sinus rhythm. And then permanent, which is sometimes called chronic, means that it's present for at least 1 year, but this term is a little bit misleading, the permanent, because even in people who've had it for more than a year, it in some cases may still be reversible. And so we still may have some treatments that could put someone back into a normal heart rhythm, even if they've had atrial fibrillation for a year or longer. Then I want to just briefly mention another condition called atrial flutter, which is a related heart rhythm disorder, but it has a regular beating of the atria rather than the chaotic beating that I showed you in an earlier slide. This is similar to atrial fibrillation, and the ventricular beats can be either regular or irregular. Many patients with atrial flutter also have atrial fibrillation, but I'm not going to talk much about atrial fibrillation, primarily because the treatment for atrial fibrillation is largely similar to treatment for atrial flutter is largely similar to the treatment for atrial fibrillation. So if your doctor says you have atrial flutter, then you can think of it as being essentially as if you had atrial fibrillation, and pretty much everything else I'm going to say would apply. What are the most common causes of atrial fibrillation? Well, by far the most common causes are high blood pressure, which is also very common in older people, coronary artery disease, which is blockages in the arteries that supply blood to the heart, especially if there's been a prior heart attack that would predispose someone to the development of atrial fibrillation. Heart valve disease, like disease of the aortic valve, narrowing of the aortic valve called aortic stenosis, other types of heart valve disease, condition known as heart failure, which means that the heart is not pumping enough blood to keep up with the body's needs, can also lead to atrial fibrillation. Chronic lung conditions such as COPD, obstructive sleep apnea, and overactive thyroid, all of those can lead to atrial fibrillation. In addition, in predisposed individuals, there are certain triggers that might bring on an episode of atrial fibrillation. One is alcohol, so-called holiday heart. So this is somebody who doesn't drink much normally, but then has quite a bit to drink on, let's say, New Year's Eve or some other holiday, and that can bring on an episode of atrial fibrillation. Various drugs, particularly cocaine, amphetamines, other stimulants, caffeine. Sometimes exercise can bring it on, sometimes stress. Low potassium or low magnesium in the blood. And importantly, atrial fibrillation occurs quite commonly after open heart surgery. Up to 50% of people with certain types of heart surgery will develop atrial fibrillation, but it also occurs commonly after other kinds of surgery in older people. So hip surgery, for example, or any other type of operation can stimulate atrial fibrillation. This is largely related to the stress of the surgery itself. What are the symptoms of AFib? Well, the most common symptom is palpitations, which is described variably by different people. It may feel like your heart is racing or skipping or fluttering or flip-flopping or pounding or some other sense of irregular heart rhythm. It can also lead to fatigue or low energy or weakness or a decrease in exercise tolerance, shortness of breath, especially with activities, dizziness or lightheadedness. Less commonly, it can lead to falling or fainting, chest discomfort, and I'll say more about this as we go forward, stroke symptoms, as this is the most important potential side effect or adverse effect of atrial fibrillation. Although atrial fibrillation can cause any or all of these symptoms can be caused by other conditions as well. So if you have palpitations or fatigue, that doesn't necessarily mean you have atrial fibrillation. That would just be one consideration. And these are relatively common symptoms that may be associated with AFib. So atrial fibrillation can cause stroke. I'll talk more about this later. And typical stroke symptoms include slurred speech, weakness on one side or the other, drooling out of one side of the mouth. And importantly, many people with atrial fibrillation don't have any symptoms at all. They're not aware of it. They could have it for weeks, months, years, and never be aware that they have atrial fibrillation. And in that situation, it's usually picked up more or less by accident. They go to see their doctor, and their doctor notices that their heartbeat is irregular, gets an EKG, and sure enough, they're in atrial fibrillation. So not all people with atrial fibrillation have symptoms or are aware that they have the condition. How is AFib diagnosed? Well, in people who have the persistent or permanent forms of atrial fibrillation, an EKG is sufficient to make the diagnosis. As I showed earlier, the EKG will show usually rapid, not always rapid, but always in irregular heart rhythm, which is different from this very almost clockwork type of heartbeat that you see in somebody who's in a normal rhythm. And so this is sufficient to make a diagnosis of atrial fibrillation if the person is in atrial fibrillation at the time that the EKG is obtained. In people who have paroxysmal atrial fibrillation, that is, it comes and goes, then a period of ambulatory monitoring may be needed to make the diagnosis. And this is wearing some type of a monitor for some period of time, which can range anywhere from a few days to a week or a month. And in people who have very infrequent episodes, like maybe every few months or 6 months or a year, then there's implantable devices that we can put in to monitor the heart rate and rhythm for several years. And we can pick up atrial fibrillation that way if it's infrequent. There's also wearable devices that may be helpful. Some of you may have heard that the Apple Watch is able to detect atrial fibrillation, and that is the case. It's pretty reliable, actually. And I think that as wearable devices become increasingly more used in general and by older people, we're going to start seeing these devices as a more frequent way that atrial fibrillation is diagnosed. Once a person has a diagnosis of atrial fibrillation, there's usually a need to perform some additional tests, partly to try to find out why the person has atrial fibrillation and whether or not anything further needs to be done. Most commonly, an echocardiogram will be performed. An echo is an ultrasound of the heart. This middle picture here is an example of an echocardiogram, and you can see labeled the two ventricles, the right ventricle, left ventricle, right atrium, left atrium. And this is a very good way to non-invasively, without any contrast, get a picture of the heart to evaluate the heart function and the heart valves and see if there's any abnormalities there that might be an explanation for the atrial fibrillation. We'll also do blood tests, including potassium level and a magnesium level. As I mentioned earlier, low levels of either of these electrolytes can trigger atrial fibrillation. And then also a thyroid test, because high thyroid may be associated with atrial fibrillation as well, and this is a relatively common problem. In some cases, a stress test will be recommended if coronary artery disease is suspected, that is blockages in the arteries. For example, if the EKG or echocardiogram shows evidence of heart damage, a heart attack, then additional evaluation for that might be recommended. And additional testing may be suggested as well, depending on individual circumstances. What are the complications of atrial fibrillation? Well, the most important, as I mentioned earlier, is that atrial fibrillation increases the risk for blood clots forming in the left atrium, and particularly in a region of the left atrium known as the left atrial appendage. So this is an example on the left here of a close-up view, left atrium here, and the left atrium has this little outpouching, which is known as the left atrial appendage. And this dark space here is blood that is not clotted. On the right, we see a close-up of the same left atrial appendage, but I hope you can see this. There's a large blood clot in the left atrial appendage. This is a person with atrial fibrillation, and they've developed a blood clot in the left atrial appendage. The problem is that if this blood clot breaks off, it can go up to the brain and it can cause a stroke. And blood clots can also go to other organs such as the kidneys, the intestines, or the legs, and can cause damage to these areas of the body as well. And it turns out that in older adults, atrial fibrillation and resultant blood clots is one of the most common causes of stroke. And we'll talk about treatment, but obviously we'd like to prevent strokes from occurring if at all possible. Atrial fibrillation can cause a small heart attack, especially if the heart rate is very fast, and it can also cause heart failure with fluid buildup in the lungs. These are less common and less serious complications of atrial fibrillation than the risk for stroke. We also have ways to identify those patients who have atrial fibrillation who are at higher risk for having a stroke. And the most commonly used way of assessing stroke risk is the so-called CHADS2-VASc score. And this is a list of various factors shown here. And each of those factors gets a score. And you can see heart failure, high blood pressure, age over 75, diabetes, a previous stroke or transient ischemic attack, other vascular disease such as coronary disease or peripheral artery disease, age 65 to 74, and women are at somewhat higher risk for having stroke than men. And you add up these points and this gives you the overall score. And the higher the score, the higher the risk for having a stroke. If you have all of these risk factors, a score of 9, that would give roughly a risk of stroke of 10 to 15% per year if something is not done to try to prevent strokes from occurring. So over 5 years, it'd be about a 50-50 chance of having a stroke. And in patients with a CHADS-2 score of 2 or more, the risk of stroke usually outweighs the risk of serious bleeding from anti-clot medications, and I'll talk more about that. And you can see that anybody over the age of 75 and women over the age of 65 have at least 2 points on the CHADS-2 VAS score, and that therefore puts them into a higher risk for stroke and benefit from having treatment with an anti-clot medication. So how is Afib treated? There's 2 main goals of treatment. One is to alleviate any symptoms that the person might have, and the second is to prevent stroke and other complications. For alleviating symptoms, there's 2 main strategies. One is to just leave the person in atrial fibrillation and control the rate with medications, trying to keep the rate in a range of about 60 to 90 heartbeats per minute. And the alternative is to try to do something to restore and maintain a normal rhythm. And it might seem like the choice between these 2 options is kind of a no-brainer, and that it has to be better to be in normal rhythm than in atrial fibrillation with controlled rate. But it turns out that long-term outcomes, including the risk for stroke, are similar with the rate control approach versus the rhythm control approach. And so with respect to long-term major outcomes, they're fairly similar. Quality of life, however, does tend to be better in people who have a normal rhythm. And later on in the discussion, one of my patients, Faye, is going to join us, and she'll be able to tell you her experience with being in atrial fibrillation versus being back in a normal rhythm. Medications for rate control include beta blockers like metoprolol, atenolol, carvedilol, calcium channel blockers like diltiazem, verapamil, digoxin, and occasionally a medicine called amiodarone. Rarely, ablation of the AV node, which is that middle node I showed you on the first diagram, can be done. It can be essentially wiped out so that no impulses go through that node, and that will control the rate, but this will also require a pacemaker. Strategies for restoring and maintaining normal rhythm, including what's called an electrical cardioversion, and this involves administering a shock to the chest under anesthesia to restore the heart to a normal rhythm. This is actually pretty effective and better than, well, roughly 90%, sometimes higher percent of people who have this cardioversion procedure will have restoration of normal rhythm. It doesn't, however, prevent recurrence of atrial fibrillation at a future time. And so sometimes you can have the shock to the chest to get you back into a normal rhythm, but a week or 2 weeks or a month or 2 months later, you have a recurrence of the atrial fibrillation. So it's an effective treatment, but it doesn't provide any long-term benefit. We can also use various antiarrhythmic medications. These are medicines which help restore and maintain normal rhythm. Some of the common ones used are amiodarone, sotalol, flecainide, and dofetilin, which is ticosine. Another approach is what's called catheter ablation. This is a fairly common procedure in which we go into the heart with catheters through through the vein. It's not an open heart procedure. And we're able to localize the area in the heart where the atrial fibrillation originates from, and we can deliver high frequency energy waves to that area of the heart, essentially create a scar there. And that is a pretty effective way of eliminating the atrial fibrillation. And the ablation is effective 70 to 80% of the time in restoring and maintaining sinus rhythm. And the most effective treatment we have at the current time is what's called a maze procedure. And this is a cardiac surgical procedure, which is usually performed in conjunction with another open heart surgery. So if somebody needs a bypass operation or a heart valve procedure, and they also have atrial fibrillation, then the surgeons will often perform this maze procedure, which is better than 90% effective in restoring and maintaining normal rhythm. There are some complications of antiarrhythmic drugs, which I don't want to spend too much time on, but they can lead to alterations in the electrocardiogram, which can predispose to some serious or even fatal heart rhythm problems. And for this reason, the initiation of at least two of the medicines that I mentioned on the previous slide, sotalol and dofetilide, require hospitalization for 2 to 3 days to monitor the EKG to make sure that no serious problems are occurring. And this is something that is not very appealing to anyone, patients, to have to come into the hospital for 2 or 3 days just to start on a medication, but it's one of the downsides of some of these antiarrhythmic medications. Then most importantly, to try to prevent stroke and blood clots in the left atrial appendage, we very frequently will prescribe medications that are anti-clot medications. These are commonly referred to as blood thinners. I don't like this term at all because these medications do not thin the blood. They prevent blood clots from forming. And so anti-clot medications is a much better term. And these medications are recommended anytime a person with any form of atrial fibrillation has a CHA2DS2-VASc score of at least 2 or higher. So I suspect that's virtually everybody who's listening in today, except for maybe Stephen, would fall into that category. And if you had atrial fibrillation, we'd recommend some type of an anti-clot medication. This would be even for people who have the paroxysmal form of atrial fibrillation, where maybe they're in normal rhythm most of the time, but as long as they have some episodes of atrial fibrillation, we would recommend an anti-clot medication. As recently as 10 years ago, we only had one anti-clot medication available to us, and this was warfarin or Coumadin. And this has been shown to be quite effective in preventing stroke, prevents 2/3 to 3/4 of strokes in people with atrial fibrillation. It's a difficult medication to use, in part because it requires relatively frequent monitoring of the blood level of what's called the INR, which stands for International Normalized Ratio. And we shoot for an INR in the range of 2 to 3, which indicates an effective therapeutic dose of warfarin or Coumadin. Another disadvantage of this medication is that it interacts with many medications and even foods. So people on warfarin often have to modify their diet, avoiding green leafy vegetables, in particular cauliflower family vegetables and that sort of thing, which is kind of a nuisance. More recently, in the past 10 years, we have available to us several new oral anti-clot medications, which are often referred to as DOACs. And these are at least as effective as warfarin with a lower risk of serious bleeding. All of these medicines, because they prevent clots from forming, can lead to bleeding, which in some cases can be very serious or even life-threatening bleeding, but the risk of serious bleeding is lower with all of these new medications. And these are dabigatran, which is Pradaxa, rivaroxaban, which is Xarelto, apixaban, which is Eliquis, and edoxaban, which I never use, and I don't remember the brand name for that. It's not commonly used in the United States. The main disadvantage of these medications is they are not yet available generically, and so they may cost considerably more than warfarin, and not all insurances will pay for them. The copay is almost certainly going to be higher than it would be with warfarin. Another approach is so-called left atrial appendage occlusion devices. I mentioned earlier that almost all of the clots that lead to stroke form in the left atrial appendage. In people who are unable to take anti-clot medications because of a high risk of bleeding for whatever reason, an alternative is to insert this device, which is kind of an umbrella-shaped device, to occlude or block off the left atrial appendage. It doesn't prevent clots from forming, but it prevents the clots from getting out into the circulation and going up to the brain and causing a stroke. And this approach, although it requires a procedure, is roughly equally effective as anti-clot medications. I just want to briefly mention that aspirin is sometimes prescribed, and although aspirin does have some anti-clot properties, and people who are taking aspirin will tend to bleed more easily if they get a cut, it's not very effective for preventing stroke in people with atrial fibrillation. So it's not a good substitute for these anticoagulant medications. A couple comments on age and AFib, just to kind of put this in a little bit of perspective. At Barnes-Jewish Hospital, where my practice is, we see an average of 4 to 5 patients age 75 or older with newly diagnosed atrial fibrillation every single day. So you can see this is an extremely common condition in an older age population. This translates to roughly 1,500 to 2,000 new patients per year. You might ask, why are older people more likely to have atrial fibrillation? And this is because some of the causes that I mentioned, such as high blood pressure and coronary artery disease, become increasingly more common with age. But it's also partly related to some of the changes that occur in the heart with aging, and that includes scarring in the atria and in the heart that can predispose to the development of atrial fibrillation. How does age affect the treatment of AFib? Well, older patients are at higher risk for both stroke and bleeding, and so we always have to balance those two possible effects in deciding how best to treat atrial fibrillation. But in most cases, the risk of stroke and the serious long-term consequences of a severe stroke outweigh the risk of serious bleeding. So in almost all cases, I will recommend anti-clot medications because the benefits outweigh the risks of bleeding. Falls and fear of falling rarely necessitate the avoidance of anti-clot medications, and in most cases should not be considered to be a reason for withholding this treatment. However, dosages of anti-clot medications and other medications may require adjustment as people get older. So to summarize, AFib is the most common chronic heart rhythm disorder, and it becomes increasingly more common with increasing age. AFib is a major cause of symptoms that in some cases can be disabling, and it's a leading cause of stroke. Treatment of AFib focuses on alleviating symptoms and reducing the risk of stroke. There are many treatment options for AFib, and there's no single best treatment approach for all patients. So we have to individualize treatment based on each patient's clinical circumstances and personal preferences. And with that, I'm going to introduce my patient, Faye. And she's been a patient of mine since at least about 2007, so about 15 years or so. And she's been hospitalized several times with Afib and has been treated with many of the treatment options that I mentioned, medications, cardioversions, ablations. And welcome, Faye. Thanks for joining us. And I'd like to begin the discussion by asking for your comments, thoughts, experiences with atrial fibrillation over the years.
Hello?
Yeah, we can hear you.
Oh, good. What does it feel like when I go into Afib? It's
Yeah.
a terrible experience. I would get very nervous and my heart would beat very, very fast. I couldn't do anything. I was absolutely exhausted when I would go into it. And I thought at first that I was having a heart attack, so I called the 911 and they assured me that it was AFib. And that's, of course, when I first met you back in 2007. And you told me that in fact is what it was. So I've had 2 ablations, and the first one was pretty successful. I was able to go about 5 years with an occasional episode of Afib, but then it became more occasional, and we had the second one, and the second one didn't work at all. I was in Afib for a month after I had it, and then we had a cardio conversion, which I've had about 5 of those, and that didn't seem to help. So you suggested we try another one of the medications. I had been on sotalol and flecainide. I went in the hospital one time where we tried Multac, but the Multac made my QTs too long, so I couldn't take it. So December of 2019, I went back into the hospital and we were trying Ticacin or Dofetilide, generic name for it. And the first pill I took got me back in rhythm within an hour after I took the pill. The second dosage was too much, so I couldn't take both dosages. So I have been on a single dose of the Dofetilide since December of 2019, and I have not had any AFib occasions since then. So I've been pleased with that drug. And I've also changed from taking warfarin, which was effective, but you have to watch your diet with your vitamin K, and that's really a chore. And you have to go at least every few weeks to a month and have blood work done, which is also hard on your old veins. So we tried and we switched over to Eliquis, and Eliquis has been a blessing. I can eat whatever I want, whenever I want, which I probably shouldn't do, but I do, and I don't have to worry. The problem with the Eliquis is that it is expensive, and my insurance towards the end of the year, I run out, and it can cost about $500 a month for these pills. But it's worth it, and I can afford to do it. So you give up other things for the things that are more important to you. And that's what I have chosen to do. So I hate AFib. I feel sorry for everybody who has to go through it, because it basically takes over a portion of your life. And there are things you would like to do that you can't do anymore. And that's difficult for a person like me who has been independent her whole life and able to do whatever she wanted to. So that's pretty much it, unless you have more questions for me.
No, really, I think you pretty much covered it. I think, you know, AFib is, it's obviously a chronic condition. In this case, it's what we call paroxysmal atrial fibrillation. So fortunately, she's been in normal rhythm most of the time, but still, at least up until 2019, December 2019, was having periodic attacks of atrial fibrillation. And I'll ask you the question, how soon after the atrial fibrillation started were you aware that you were back in AFib?
Oh, I knew all the time.
Yeah.
So immediately, you know.
Yeah. And then also immediately when you went back into a normal rhythm, right?
Right. And immediately when I went into AFib, I knew instantly what it was. The hard thing for me was you told me on the first visit, or maybe the second in the hospital, that AFib would not kill me, but I could have a stroke and the complications from the stroke could. So that was difficult for me to realize in the beginning, that I wasn't going to die every time my heart started acting up.
And so, you know, I mentioned earlier that some people have much less symptoms. Some people don't have any symptoms at all, but even in people who have no symptoms, they're still at risk for having blood clots form and having a stroke. So they'll still need to have appropriate treatment, which in many cases will include an anti-clot medication. So at this point, I'd like to open it up for questions. You feel free to use the chat or to just jump in. We have 2 questions in the chat. How does atrial fibrillation relate to premature atrial? So premature atrial contraction is a single extra beat. Sometimes they can occur frequently, sometimes they can occur from runs, but it doesn't produce the same type of persistent, chaotic beating of the heart that atrial fibrillation does. Sometimes people who have very frequent atrial fibrillation, APCs or atrial premature beats, may be at higher risk for developing atrial fibrillation later on, but that really becomes a separate problem if atrial fibrillation actually develops. The second question is, can AFib be related to stress? And stress is one of the things that can precipitate an attack of atrial fibrillation. So if something stressful happens in somebody who is predisposed for whatever reason to have atrial fibrillation, or who has already had prior episodes of atrial fibrillation, stress might trigger an attack of atrial fibrillation. We're starting to run into multiple questions here, so I'll try to answer them as best I can. Have you heard anything about generics coming out for Eliquis? The patent is ending in 2021, and that is actually true. That the patent for Eliquis is going to be running out. That, however, doesn't necessarily mean that a generic will become available. And part of the reason for that is because drug companies do various manipulations to try to delay generic medications coming out. Eliquis, as you might imagine, is a blockbuster medication for the pharmaceutical company that makes it. They'd like to maintain exclusive rights to that medication for as long as possible. They're willing to spend a lot of money to prevent it from becoming a generic. That's not the best thing for all of the people around the US who have atrial fibrillation and might benefit from a generic form of Eliquis. But I think that it does happen nonetheless, and therefore I can't say when a generic version of Eliquis might actually be available in the United States. I would not be surprised if it's a couple more years or longer. Next question, I have an implanted monitor with a dead battery. Is it okay to leave it in? Well, I would say you need to really talk to your doctor about that. I think that it depends what the monitor was put in for in the first place. The dead battery itself is not likely to be causing any problems, but and why you had the monitor that would determine whether or not the monitor needs to be removed or the battery needs to be replaced. So it's not a question that I can really provide a definitive answer to. What happens if you go into Afib and don't seek emergency help? Well, most likely nothing. If you're not having severe symptoms and don't feel like you need to have any immediate treatment for it, it's not necessarily required to get emergency help. I would, however, recommend that you talk to your doctor about it fairly soon, especially if this is the first time that you've had atrial fibrillation or think that you've had atrial fibrillation, because as I mentioned, there are treatments, particularly anti-clot medications that need to be started in order to lower the risk of stroke or other serious consequences from the atrial fibrillation. But for example, Faye didn't go to the hospital every time she had an episode of atrial fibrillation. There are many occasions where she would wait a couple days before even calling me, hoping that it would go away. And sometimes it did go away. And then if it lasted for long enough and it was bothering her enough, then she would call me and then we'd figure out what the next plan, next stage of the plan would be. So an episode of atrial fibrillation doesn't necessarily require hospitalization or even a call to the doctor right away about it. It certainly doesn't necessarily require an emergency visit. Skipped beats. So skipped beats, it's sort of a confusing term. Skip beats is what people sometimes experience. They feel like their heart is skipping a beat. And that's usually because there's an early beat. And after that early beat, there's a pause. And that pause feels like a skip. And so people will describe palpitations or the sensation in the chest that they've had a skip in their heartbeat. And it could be atrial fibrillation. Some people might describe atrial fibrillation or palpitations related to atrial fibrillation as a sensation that the heart is skipping, but single extra beats or several extra beats can be described by people as feeling like skip beats or sensation that the heart is skipping. Next question, the risk of the Watchman procedure. So the Watchman procedure is, I'm going to go back to my slides here. Sorry. Just pull that diagram back up. Hold on a second here. So the Watchman procedure, the Watchman device is the name of this device that's inserted to block off the left atrial appendage. It's inserted using catheters, so it's not an open heart procedure. It's a pretty safe procedure. It's not associated with a lot of risk. It has to be positioned perfectly in the left atrium. And since you're not actually in there, you're steering it with catheters, there's a possibility that it won't be perfectly positioned, in which case there can be a leak around the procedure, around the device. And if that's the case, then it would still be possible for a clot to escape, so to speak, get out, go up to the brain. And if that happens, sometimes people will still need to be on anti-clot medications. We usually recommend that people be on some type of protection from clot formation for anywhere from 1 to 3 months after having one of these devices put in. It may not be full anti-clot medication. It may be something like aspirin and a medication called Plavix or clopidogrel to prevent any clots forming around this particular device. But by and large, it's a pretty safe device. And as I said, it's roughly equally effective to these blood clot, anti-blood clot medications for preventing strokes from occurring. An advantage of the device is that because in the long run, it doesn't require these anti-clot medications, there is a lower risk of bleeding. And so this is usually the situation in which we might consider one of these devices in an individual with atrial fibrillation who really has a high risk of bleeding or who has frequent serious bleeding when taking one of these medications, and just seems like the risk of bleeding may outweigh the risk of the medication in reducing stroke, then we might consider putting one of these devices in. I have to say, in my own practice, this constitutes a very small minority of my patients with atrial fibrillation in whom I would recommend this type of a device. All right, let's see here. Difference between Multec over flecainide. Well, Multec and flecainide are both medications, antiarrhythmic medications to try to maintain a normal heart rhythm. There's advantages and disadvantages of both of them with respect to possible side effects, and both of them are usually going to be used in, first of all, younger people who are less likely to have side effects related to these medications, but can be used in older people as well in certain circumstances. They're not two of the more commonly used medications for atrial fibrillation, which are really amiodarone, which is also called Pacerone. That's the brand name of amiodarone. Dofetilide, which is Ticacin, and Sotalol. Those are the three most common antiarrhythmic medications that are used in atrial fibrillation. But in some cases, Multec and flecainide can also be used. Multec is dronedarone, is the generic name of Multec. Do we have an antidote to reverse bleeding complications from Eliquis? I heard a year or two that they were developing one, and that's a great question. An earlier limitation of these newer medications was that we didn't have any kind of an antidote if bleeding would occur. And so if someone was on Eliquis in 2013, 2014, and they had serious bleeding, we would simply have to wait until the effect of the medication wore off or transfuse blood products to try to stop the bleeding. But now we have very effective medication to stop pretty much instantly the effects of these newer medications to prevent bleeding. These anti-clot medications are generally administered in the hospital. They're pretty expensive, but they're extremely effective. They're not something that you're going to be buying at your pharmacist to use if needed. It's something that really is reserved for serious bleeding related to any of these medications. But they're approved and, as I said, quite effective. Then we have, thank you so much for this info. Wonderful presentation. Thank you very much for that comment. And let's see, we're running towards the end of the hour here. Anybody else have any questions?
Could I ask you a question, Doctor?
Sure.
You made reference to when we talked about skip beats being an extra beat, but that the delay is why people think it's skipped.
Yes.
Is that something that would cause stroke? Is that something that is, needs to be pursued with these kind of medications you're talking about?
Not usually. If it's extra beats, we asked earlier about atrial premature contractions. Those are premature beats emanating from the upper chambers of the heart, the atria. We also commonly have premature beats originating from the lower chambers that are referred to as ventricular premature contractions or ventricular premature beats. Both of these are very common, and they become increasingly common as people get older. And usually there's nothing that needs to be done about them. They're not serious, and they only really need to be treated if they're particularly bothersome to the individual. So if somebody's having atrial or ventricular premature beats very frequently and it's disrupting their activities, they can't sleep because of them, then we might recommend some treatment for them. But they're not the same as atrial fibrillation. They don't lead to strokes, and they don't require anti-clot medications.
Oh, thank you, Doctor.
All right, is right bundle branch block a risk factor? So right bundle branch block is an abnormality of the heart's conduction system. There's also a left bundle branch block, which is fairly similar. And these also become increasingly common as people get older, but they might indicate that there's some type of heart condition going on, but in and of themselves, they're not risk factors for the development of atrial fibrillation. And in most cases, they don't require any kind of a specific treatment. If the right bundle branch block and left bundle branch block occur simultaneously, then that's going to lead to complete block of the heartbeat, and that situation is going to require a pacemaker. But that's pretty rare. All right. I see a couple.
What about a leaking mitral valve?
Leaky mitral valve. So that's a mitral valve is one of the two valves on the left side of the heart. And what it means when it's leaky is that it's not closing properly. And that allows blood to go in a backwards direction. So when the left ventricle contracts and normally propels blood out of the heart to the body, that some of that blood goes backwards into the left atrium. And it's not really leaking. It's kind of don't like the word leaky because it seems to sound like blood is leaking out of the heart. It's not happening. It's just going in the wrong direction. It's going backwards from the left ventricle to the left atrium. And there's various causes of this condition and also varying severity of it. And if it's severe, where a lot of blood is going backwards, then sometimes that will need to be treated initially with medications or in some cases with some type of a procedure, either a valve repair or a valve replacement. Brian, I see.
And would that be the reason that the enlarged chambers, two enlarged chambers, if you have the leaky valve?
Yes, So if you have mitral regurgitation or leaky mitral valve and it's severe, then that could lead to enlargement of the left atrium because there's a lot of blood going into the left atrium as a result of the leaky valve. And that's inevitably going to lead to enlargement of the left atrium. And an enlarged atrium is a risk factor for the development of atrial fibrillation. So as the atrium gets larger, it's less likely to be able to conduct a normal impulse, sinus impulse, and more likely to develop this erratic type of impulse that I showed you that represents atrial fibrillation. So I mentioned that heart valve disease is one of the causes of atrial fibrillation, and that would include a leaky mitral valve and also a narrowed mitral valve, a condition called mitral stenosis, which we don't see so much anymore, but that's a common condition of rheumatic heart disease.
Thank you.
All right.
Brian, did Brian have a quick question? He raised his hand.
Yeah.
Yes. On one of the slides, you had some information about warfarin. I've been taking it for about 10 years. And at the beginning, I was told, don't eat any cranberry products or the green part of salads. And after about a year, my doctor said, oh, don't worry about it. Just do what you got to do. Now, I know that there are times when I've had to stop because I had my left knee replaced and there was pain blockers and other things. But any truth to the food stoppages, certain foods in connection with warfarin?
So it's definitely true that foods that are high in vitamin K, and that includes green leafy vegetables, broccoli, cauliflower family, salads and so forth are high in vitamin K. They interact with the warfarin and reduce its effectiveness. And so it is true that a diet that is high in those kinds of foods may lead to a high requirement for the warfarin dosage. So you may need to take a higher milligrams of the warfarin if you're eating a lot of that. I don't recommend for my patients who are on warfarin that they stop eating those foods altogether, because those are healthy foods that people like. What I recommend is a relatively steady diet of them so that you don't have a giant salad with lots of broccoli and cauliflower one day and then go 4 days without having anything like that. Just sort of a regularly, a fairly steady diet of the high vitamin K foods, and then that won't have too much effect on the regulation of the warfarin. So in answer to your question, it's true, but that there are interactions with diet, but it doesn't necessarily mean that you can't eat any of those foods.
Thank you.
Dr. Rich, I'm sure we could keep you here for a whole lot longer, but you've been very generous both with your time and your information. And so on behalf of the Mirowitz Center, I want to thank you so much for joining us. This has really been an incredible experience because you took something rather complicated and in some ways a little intimidating and made it much more understandable. I also want to thank Ms. Shearer for joining us because she's one of us and she explained it in layman's terms that were both helpful and insightful. So thank you both very much for being with us and for joining us at the Mirowitz Center today.
Thank you.
Thank you very
Thank
much.
you.
Thank you,
Thank you.
Fane, as well, for joining us.
Thank you.
Opportunity to speak to you all.
Bye-bye.
Bye, everyone.